Good evening or good morning. This is again Professor Nick, and today is let me check Saturday, March 5th, around 11 p.m. Brooklyn, New York time. We'll go over some pediatric orthopedics and ID problems. Let's start from the first slide. So the first slide was showing on the right upper corner beautiful animation for newborn hands, I guess. Anyway, the table discuss different clinical situations in a musculoskeletal pediatric disease. Let's start from the beginning. Congenital hip dysplasia usually occurs in infants. How it presents? It's found usually on newborn screening exam. What we do is ortho and bar walk maneuver, and we can hear clicking or clicking on clunking sound of the hip. The treatment is with public harnessed. Second clinical situation, this is leg web Perthes disease, which is the fancy name of avascular necrosis of the femoral head. Frequently presents at age 2 to 8, and patient presents with painful limp. On X-ray, we can see joint effusion and widening. The treatment is with rest and NSAIDs, followed by surgery of the both hips. If one necrosis, eventually so will be the other. So the third clinical situation, this is a slipped capital femoral epiphysis. I'm sorry for my accent. Epiphysis. Usually presents in adolescent age, especially in obese patients. It presents with painful lip, and the leg is externally rotated. X-ray shows widening of the joint space, and the treatment is internal fixation with pinning. Let's go to the next slide. Here, on the left lower corner, there is very nice X-ray for bald legs, which are common physical finding on rickets, vitamin D deficient rickets. So let's talk about this clinical situation. Rickets is a disorder caused by a lack of vitamin D, calcium, or phosphate. Usually leads to softening and weakening of the bones, making them more susceptible to fractures. Children are 6 to 24 months old, and they have the highest risk because the bones are rapidly growing. There are three main etiologies of rickets. Number one, vitamin D deficient rickets, which is caused by lack of enough vitamin D in the child's diet. Number two, vitamin D deficient rickets when there is no, the child is not able to convert 25-OH to 1,25-OH2, and therefore the infant is dependent on vitamin D supplementation. And the last one, this is X-linked hypophosphatemic rickets, which occur when the kidney defect results in inability to retain phosphorus. Without phosphate, adequate bone mineralization cannot take place, and bones are weakened. On the right side of the slide, the patients with rickets presents with ulnar or radial bowing and wavering gait due to tibiofemoral bowing. The diagnostic test, this is a rachitic rosary. On the chest x-ray appears a rachitic rosary on the costochondral joints with cupping and fraying of the epiphysis. Bow legs are characteristic sign. The treatment is we need to do replacement of phosphorus, calcium, and vitamin D in the form of ergocalciferol or 1,25-OH2 calcitriol and annual blood vitamin D monitoring. Here there is a clinical tip. The American Academy of Pediatrics recommends the infants who are excessively breastfed to be given vitamin D supplement beginning of age of 2 months, On the right lower side there is a table which shows different type of vitamin D disorders and chemical consequences. Let's start from the first one. Vitamin D deficient. The calcium is normal or decreased. The phosphate is decreased. 1,25-OH2 vitamin D is decreased, and 25-OH vitamin D is also decreased. So everything is decreased here. We have to remember. Vitamin D dependent. Number 2. The calcium is decreased, the phosphate is normal, the 1,25-OH2 vitamin D is decreased, and 25-OH vitamin D is normal. The number 3 form, X-linked hypophosphatemia, the calcium is normal, the phosphate is decreased, 1,25-OH vitamin D is normal, and 25-OH vitamin D is normal. Let's go to the next slide, slide number 4. Here we need to discuss lead poisoning. We're looking for a child with recent loss of appetite, intermediate abdominal pain, vomiting, decreased hours of sleep at night, and withdrawal from school activity. Learning disability and behavioral problems are very common in children with lead poisoning. The best initial test is capillary blood finger stick for lead level. The most accurate test is a serum venous blood level, and intervention is needed when the value is greater than 10 micrograms per deciliter. The best initial step is to remove the child from the offending exposure, and depending upon the degree of lead poisoning, chelation therapy with demercaptopro or succimer may be indicated. And we have 3 forms: severe intoxication over 70. The treatment is IV dimercaptopro/BAL, BAL. Moderate intoxication is when between 45 to 69. The treatment here is oral succimer as inpatient. And worst form is mild intoxication, 44 and less. We need to follow up as an outpatient, and we need to do lifestyle changes, which vary based on the lead level. Let's talk about so-called OSD or Osgood-Schlatter disease. OSD presents in young athletes with chronic pain over the tibial tubercle. The pain affects athletes which run and jump as a great deal, as well as children which are experiencing bone growth. On physical exam, it shows tenderness to palpation over the tibial tubercle without any other signs of the knee instability. The cause of OSD is repeat knee extension leading to microavulsions of the tibial tubercle. The diagnosis is made on clinical history and exam. We have to remember this. Physical therapy, rest, and knee immobilization will improve the symptoms, and the patients normally have to complete relief of the symptoms by age of after 12 or 24 months. So they have complete relief of the symptoms after 1 or 1.5 years. On the right lower side of the slide, we can see X-ray of a patient with Osgood-Schlatter disease, OSD. Let's go to the next slide. Next slide we'll discuss is osteogenesis imperfecta or OI. O like old, I like ice. OI is the most likely diagnosis when a young child presents with repeated fracture caused by fragile bones, blue sclera and early deafness. The most accurate test for OI is a skin biopsy which analyzes for collagen synthesis by culturing dermal fibroblast. Wow. What the hell is this? There is no cure for OI. Therapies aim at fracture management, increased bone mass, and correcting of deformities. On same slide number 5, we see a table where we discuss 3 clinical situations. Ewing sarcoma. On X-ray, we see onion skin pattern due to lytic lesions causing laminar periosteal elevation. Most accurate test is analysis for translocation of T1122 via bone biopsy. And the therapy is multi-drug chemotherapy as well as local disease control with surgery and radiation. So it's chemo, surgery, and radiation. The treatment. The next clinical situation is osteogenic sarcoma. X-ray appear that there is a sclerotic destruction caused by sunburst appearance. Most accurate diagnostic test, this is a CT scan of the leg, and the therapy includes chemotherapy and ablation surgery. And the last one, this is osteoma. We have on X-ray around central lucidity with sclerotic margin. Then the most accurate test, this is CT scan or MRI of the affected leg. And the treatment is NSAIDs for pain. And the condition will be resolved spontaneously after a while. Let's go to the next slide. Slide number 6. Here we need to discuss the pediatric infectious disease. We'll start with the clinical situation when we have a 6-month-old infant brought in by his mother after that she describes a seizure. The child had a fever of 103 Fahrenheit for the last 3 days and has been very irritable lately. The child appears unresponsive but is breathing. Physical exam reveal markedly delayed capillary refill and blood pressure of 80/20. The question is, what is the most likely diagnosis? A, febrile seizure, B, absent seizure, D, dog bite, C, dog bite, D, cocaine withdrawal, and E, epilepsy. The right answer is A, and the explanation for that is the following. This child has a febrile seizure secondary to sepsis. The real take-home message is, in this case, is to evaluate the child for underlying cause of sepsis. Understanding he has had a febrile seizure is only on the surface of the case. A full service evaluation must be ordered, which includes CBC with differential of the blood and urine culture, urine analysis, chest X-ray, and lumbar puncture. And here the note is, if irritability or lethargy is mentioned, is equal to meningitis. The rest of the explanations are not valid. On the right side of the slide, there is a very nice picture or animation of possible COVID virus. Looks to me like COVID. Let's go to the next slide. Slide number 7. Here there is a table of neonatal sepsis and treatment protocol. There is so-called, and one clinical suggestion or clue. There is so-called torch syndrome, which includes toxoplasmosis for T, O for other infections like syphilis, R for rubella, C like cytomegalovirus, H like herpes simplex virus. So let's go over neonatal sepsis. The most common cause, the cause is pneumonia and meningitis. The most common organisms are 1. Group B strep, B. E. coli, C. Staph aureus, and D. Listeria monocytogenes. I'll say Listeria mono. It's too long. Then the diagnostic test we have to do, this is blood cultures and urine culture and chest X-ray. The treatment is with ampicillin and gentamicin. And on our figure 7.12, we'll see a protocol how to treat neonatal sepsis. If it is early in age, it's caused by group B strep mostly, then E. coli and Listeria. We need to give IV fluids, cultures, and antibiotics, and treatment with ampicillin, gentamicin, and cefotaxime. If it is late, the most common is Staphylococci, then E. coli and group B strep, and the treatment, we need to do IV fluids, culture, and antibiotics, and the treatment is with ampi, genta, and cefotaxime. All right. Let's go to the next slide. Slide number 8. On this beautiful table, on this slide, we'll discuss so-called torch infections. Toxoplasmosis. Let's start from the first one, toxoplasmosis. It presents like chorioretinitis, hydrocephalus, and multiple ring-enhancing lesion on CT, which is caused by Toxoplasma gondii. The diagnostic test is the best initial test is elevated IgM to Toxoplasma. Most accurate test is PCR for toxoplasmosis. The treatment is pyrimethamine and sulfadiazine. The next is syphilis. Usually presents with rash on the palms and soles, sniffles, and frontal bossing. Also, there is a Hutchinson, 8 nerve palsy, and saddle nose. The best initial test is VDRL or RPR. The most accurate test is FTA, ABS, or dark field microscopy. And the treatment is penicillin. The next test is rubella. The next clinical situation is rubella. Rubella presents with PDA, cataracts, deafness, hepatosplenomegaly, thrombocytopenia, blueberry muffin rash, and hyperbilirubinemia. Diagnostic tests usually maternal IgM status along with clinical diagnosis. Each disease manifest must be individually addressed. The treatment is supportive. Next category is CMV. CMV presents with periventricular calcification with microencephaly, chorioretinitis, hearing loss, and petechiae. The best initial test is urine and saliva viral titers. The most accurate test is urine and saliva PCR or viral DNA. The ganciclovir, the treatment is with ganciclovir with signs of end organ damage. The last one is herpes. We have week 1, shock and DAC, week 2, vesicular skin lesions, week 3, encephalitis. This is the clinical presentation. The best initial test is Sang smear, and the most accurate test is PCR. The treatment is with a sequovir and supportive care. Let's go to the next slide, which is slide number 9. Here on this table, we'll discuss some viral childhood illnesses. Let's start with number 1, varicella. Etiology is varicella zoster virus. The clinical presentation is multiple high pruritic vesicular rash, which began on the face and with possible fever in malaise. The best initial test is a Zank smear, Zank, T-Z-A-N-C-K smear, which showing multinucleated giant cells. Most accurate test is a viral culture, and the treatment is supportive. The second one is rubeola or measles. It's caused by paramyxovirus and presents with the 3 C's: cough, coryza, and conjunctivitis, and so-called Koplik spot. K-O-P-L-I-K spot, which is basically grayish macule on the buccal mucosa. Diagnostically, is mostly clinical diagnosis. The most accurate test is measles IgM antibodies. The treatment is supportive. Number 3 disease, this is a fifth disease, or erythema infectiosum. It's caused by parvovirus B19, presents with fever, URI, which progress to a rash which is called slap cheek appearance. Diagnostically only by clinical diagnosis, and the treatment is supportive. Roseola is a herpes virus type 6 and 7, presents with fever and URI, which progress to rash. Diagnostically is clinical diagnosis, and the treatment is supportive. Mumps is the last clinical situation. It's caused by a paramyxovirus, presents with fever, classically parotid gland swelling, and possible orchitis. Again, the diagnosis is clinical, the treatment is supportive. So here, the last 3 diseases, fifth disease, roseola, and mumps, we need to know that the diagnosis is clinical and the treatment is supportive. The fifth disease is caused by parvovirus B19. Roseola is caused by herpes virus type 6 and 7, and mumps by paramyxovirus. So I'll go to the next slide, which is slide number 10. On the left side of the slide, we'll see a child with scarlet fever, the hands with specific rash. Scarlet fever is diffuse erythematous eruption it's concurrent with pharyngitis. It's caused by erythrogenic toxin made by Streptococcus pyogenes and typically lasts 3 to 6 days. Presentation. Scarlet fever presents with the classical pentad of fever, 1, 2, pharyngitis, 3, sandpaper rash over the trunk and extremity, 4, strawberry tongue, and 5, cervical lymphadenopathy. Diagnosis and treatment of the scarlet fever. The diagnosis is usually clinical, but can be correlated with elevated anti-streptomycin or titer, ESR, and CRP. The treatment is penicillin, azithromycin, and cephalosporin. On the right side of this slide, let's discuss Kawasaki disease. Kawasaki disease is necrotizing febrile vasculitis of medium-sized vessels, which primarily affects the large coronary blood vessels. It occurs in children. You gotta look for a child which is more than 5 days with fever, and 5 of the following criteria: 1, rash; 2, mucositis; 3, edema and erythema of the hands and feet; 4, cervical lymphadenopathy; and 5, limbic sparing bilateral conjunctivitis. The other symptoms which suggest Kawasaki disease are elevated WBC, platelet counts, transaminase, and acute phase reactant, such as anemia and pyuria. Here there is a clinical tip. Steroids do not help Kawasaki disease, and they increase the formation of aneurysm. So the treatment, you give IVIG and aspirin as soon as the diagnosis is made to prevent development of coronary artery aneurysms, the most important complication of this disease. So you need to give IVIG and aspirin. Although the mechanism of action of IVIG is unknown, this treatment regimen reduces the risk of coronary artery aneurysms. Wow. Let's go to the next slide, the last slide, which is slide number 11. We're almost done. On the left side of the slide, we'll discuss retropharyngeal abscess. Retropharyngeal abscess are deep neck space infections. Because of their potential for airway compromise and other catastrophic complications, they can pose an immediately life-threatening emergency. The most common cause of group A beta hemolytic streptococci. Look for a patient which decrease or painful range of motion of the neck and jaw. Some patient may present with muffled hot potato voice and deviation of the uvula. CT of the neck can distinguish between abscess and cellulitis. Treatment is incision and drainage of the abscess, the best therapy, and fluid should be collected and sent for culture. While waiting cultures, we need to administer ampicillin sulfobactam. Wow. And the last one on this slide, in the end of the lecture, is let's talk about malignant otitis externa. This is on the right side of the slide. Malignant otitis externa is an invasive infection of the external auditory canal and skull base due to Pseudomonas aeruginosa. Patients with malignant external otitis classically presents with otalgia and oturia, extreme otalgia and oturia. The best initial test is CT scan of the skull base. Biopsy is the most accurate test, and ceftazidime is an anti-pseudomonal drug which often used in children with malignant otitis externa. And there is a clinical tip. Topical therapy is always wrong answer for malignant otitis externa. And dear students, this is the end of the last slide, and this is the end of the pediatric section for PAs and MPs board review session. Once again, my name is Professor Nick, and you can reach me on my email, NICK, M like Mary, D like dog, number 1 @gmail.com. Good night.